Good afternoon, everyone. Thank you for joining us for our Thursday afternoon educational webinar with the Cholangiocarcinoma Foundation. I'm Melinda Bikini, Director of Advocacy with the Cholangiocarcinoma Foundation, and today we are very excited to have Drs. Fung and Dr. Baker from the University of Chicago, but I am going to pass it over to Lisa Crane, one of our volunteers and research advocates with the Cholangiocarcinoma Foundation, to introduce the doctors. Go ahead, Lisa.
Thank you, Melinda. I'd first like to introduce Dr. Baker, who is a hepatobiliary and liver transplant surgeon at the University of Chicago Medical Center. She's a nationally renowned expert in living donor liver transplantation. Dr. Baker works closely with physicians in the University of Chicago Medicine's Comprehensive Cancer Center to provide multidisciplinary approaches to personalized care for hepatobiliary malignancies. Dr. Baker is an active researcher. Her scholarly work focuses on liver transplants, such as downstaging complex hepatobiliary tumors to resectability and the ethical implications of using social media for organ donation opportunities. Dr. Baker was an invited participant at the 2016 White House Summit to reduce the organ waiting list and facilitate research breakthroughs. We are so fortunate to have Dr. Baker as part of our cholangiocarcinoma community, improving the lives of bile duct cancer patients daily. Thank you for joining us, Dr. Baker.
Thank you.
I would like to introduce Dr. John Fung, who joined the University of Chicago Medicine in 2016 as Chief of Transplant Surgery and the inaugural director of their Transplant Institute. He was the former chairman of the Cleveland Clinic's Digestive Disease Institute and director of Cleveland Clinic Center for Transplantation. Prior to Cleveland Clinic, John trained at UPMC with Dr. Thomas Starzl, who was known as the father of modern transplantation. John is a Thomas Starzl Award recipient which honors international leaders in organ transplantation. John Fung credits Dr. Starzl for pushing him to redefine the boundaries of what is possible in organ transplantation. Thank you, Dr. Fung, for serving our cholangiocarcinoma community and patient population with your expertise, passion, and care.
My pleasure.
I just want to jump in real quick because I forgot to say at the beginning that there will be time for question and answers after the presentation, and you all are welcome to type in any questions you have into the chat room and we will get to them at the end. All right, I'll turn it over to you, Dr. Baker.
All right, thank you, Melinda, and thank you, Lisa, for that lovely introduction. Thank you to everybody involved for allowing us to participate in this really remarkable effort to expand the boundaries of what we can do for bile duct cancers. I'd like to introduce you to some ideas that we have around the idea of liver transplant for cholangiocarcinoma, and specifically what we believe are strong considerations for living donor liver transplantation in this realm. So as you know, malignancies of the bile ducts are called cholangiocarcinomas, and they're classified generally as intrapatic, perihilar, which is hilar, or what is traditionally known as the Klatskin's tumor, or distal. We're going to be focusing on intrahepatic and perihilar tumors in this talk. So proximal duct cholangiocarcinoma, both intrahepatic and hilar, are the second most common primary hepatic malignancies worldwide. They're certainly known to be a higher incidence of men, and differing exposures to risk factors are likely responsible for varying rates around the world. There certainly are established risk factors and possible risk factors, but I'd like to mention that we as a community have been facing more and more young people with no identifiable risk factors who present with this disease. So we believe this is a really important area for research, but also a really important area where people have to recognize that they should reach out to their doctors should they experience any symptoms like itching or turning yellow or having very dark urine or very light stools. So the diagnosis, especially for hilar cholangiocarcinoma, which is kind of traditional transplant indication for cholangiocarcinoma, I'll outline, is really problematic. There's certainly biochemical markers which are traditional, but they're certainly not perfect and can be elevated in other cancers and conditions. Radiologically, it's also a really difficult disease to diagnose. Often there's a liver mass, which is hilar intrapatic, but often very difficult to identify on traditional imaging. There can be short dominant strictures on cholangiography or rapid progression of stricturing, but again, often very subclinical and difficult to diagnose. PET scan has really taken a large role in our diagnosis and in our management of patients. So you'll find if you have a person who comes to us that often we ask for a PET scan, which really aids us in understanding the biology of the disease that's presenting. Endoscopic ultrasound certainly plays a large role, as well as ERCP. Endoscopic ultrasound can be used for both the diagnosis as well as the staging of cholangiocarcinoma, and it's becoming increasingly used due to limitations of ERCP bile duct sampling. And features of cholangiocarcinoma on EUS can be very variable, but usually include potentially a hilar mass, a malignant appearing lymph nodes, and thickened bile ducts, but often is very user dependent in terms of who is actually doing the EUS. Pathologically, we do understand how to diagnose cholangiocarcinoma, but again, often a diagnostic conundrum. And we know that we often have to send out for genetic markers to really understand what we're dealing with. The treatment algorithms traditionally have been surgical resection, liver transplantation, or what has always been called palliative treatments, including chemotherapy, biliary stenting, and photodynamic therapy. What we're starting to recognize, and I'll get into this later in the talk, is that often a combined approach may offer actually improved outcomes and improved possibilities for long-term survival. So when we consider resection versus liver transplant in hilar cholangiocarcinoma, the patients with clearly resectable de novo hilar cholangio should be treated with radiation therapy because there is no evidence to date that they would, resection rather, sorry, because there's no evidence to date that they would fare better with neoadjuvant therapy and liver transplant, although that algorithm, I would argue, may be evolving in the near future as well. People with locally unresectable de novo hilar cholangiocarcinoma and meeting transplant criteria, which we'll go over in a moment, should be considered for neoadjuvant therapy as well as liver transplantation. Survival after initiation of neoadjuvant therapy and subsequent liver transplant is clearly sufficient to justify the use of both a deceased, if you can find one, or potentially a living donor liver. The decision to proceed with resection versus liver transplantation for patients with borderline resectable de novo hilar cholangio remains unclear and very difficult. And we encourage discussion with a multidisciplinary team to make a decision about the best personalized approach for any given patient who comes to us. The decision process should consider the center's track record predicting resectability and lymph node involvement, the availability of either a deceased donor or a living donor graft, and the individual patient's suitability for aggressive neoadjuvant therapy as well as liver transplantation. Bottom line, every patient should be considered individually for their treatment algorithm. The basic principles traditionally for liver transplant for hilar cholangiocarcinoma are unresectable hilar tumors, generally above the cystic duct, and cholangiocarcinoma presenting in a patient with primary sclerosing cholangitis due to the inherent liver disease. The diagnosis is made in a very traditional way, and there are center-specific exclusion criteria which can include, but don't absolutely include, patients with prior abdominal radiation, patients who have undergone a transperitoneal biopsy of the tumor or open exploration with violation of the tumor plane, diagnosis of a previous malignancy within the 5 years prior, and presence of intrahepatic mets or extrahepatic disease. The presence of lymph node metastases has traditionally been considered a contraindication, although these two are now being considered individually how much they would contribute to the patient's overall survival. And generally, patients who are younger than 18 and older than 70 years of age at presentation really have to be considered as to what is the best option for those patients. We all know the traditional Mayo protocol, which has really changed the world of cholangiocarcinoma and allowed us to really offer patients significantly improved survival. But I would like to mention that as people come forward for what we traditionally call the Mayo protocol, I think that we are really pushing the limits of what we can do and have broadened this to include a wider variety of patients. So liver transplantation for unresectable perihilar cholangiocarcinoma has been demonstrated to have efficacy and excellent survival by the Mayo group, who have published on this widely. They've shown in small series and now in larger series that their outcomes are really remarkable. At 5 years, they have a 76% 1 year, 76% patient survival, which is really remarkable when you think about it. They've validated this with larger studies around the world. And the overall survival, when you compare resection versus liver transplantation, is significantly better with transplantation in this very selected group of patients. And further, recurrence-free survival, when you look at resection versus liver transplant, again, is better for the liver transplant patients. So the question of liver transplant for hilar cholangio is something that we all accept, but know that we even have to do better. And I think we're on the cusp of doing that. But flipping to intrahepatic cholangiocarcinoma, this is still a more controversial topic, but there is demonstrable evidence that small early intrahepatic cholangiocarcinomas certainly can be treated with liver transplantation. The actuarial patient and graft survivals are actually excellent for small cancers, but in advanced intrahepatic cholangiocarcinoma, the outcomes have not been as good. But remember, this data was looking at patients who had not had a multidisciplinary approach to their cancers prior to consideration for liver transplantation. Certainly, the cumulative risk of recurrence amongst patients with very early versus advanced ICC also points this out, that the advanced group had a very early recurrence risk, again indicating that we have to do better, and that's exactly what our group at University of Chicago is trying to do. So in 2021, how do we look at cholangiocarcinoma? We know that hilar cholangiocarcinoma, although it remains a diagnostic challenge, we know that we can help patients by considering advanced surgical options, including liver transplantation. Liver transplantation certainly offers prolonged survival in selected patients with unresectable hilar cholangiocarcinoma. But we believe that further studies are needed to better define the role of liver transplant and resection in locally advanced intrahepatic cholangiocarcinoma, and certainly also in mixed HCC cholangiocarcinoma patients. We've developed an effort which has really been mirrored worldwide of liver transplant oncology, consideration of novel indications of liver transplantation for patients who otherwise weren't considered as candidates for liver transplantation. And certainly this includes this large group of locally advanced intrahepatic cholangiocarcinomas who clearly derive a survival benefit from consideration for transplant. So the Houston Methodist Group, in conjunction with MD Anderson, published the first series of liver transplant for locally advanced intrahepatic cholangiocarcinoma using a multidisciplinary downstaging approach with adjuvant and neoadjuvant therapy included in the treatment algorithms. This was a really exciting paper, and they had remarkable results and really kind of pushed ahead this whole field of liver transplant oncology and the focus on locally advanced intrahepatic cholangiocarcinoma. We at University of Chicago, under myself, Dr. Fung, Dr. Anjana Pillai, who's our hepatologist, we have a dedicated medical oncologist, as well as a dedicated interventionalist who is in IO, interventional oncology, or interventional radiologist. We've developed a multidisciplinary treatment team where we really look at surgical options for locally advanced intrahepatic cholangiocarcinoma with a dedicated multidisciplinary approach to each patient with a personalized treatment algorithm. Our algorithm is very loose in that everybody is considered for a personalized approach. And once they get to their surgical options, we are very clear that these have to be considerations for either advanced hepatobiliary options, including Dr. Fung has really pushed for ex vivo auto transplantation in appropriate cases, or potentially for liver transplant. And I will show you in a bit why I think that living donor is really the best option for most of these patients. So when you think about liver transplantation, it should be offered to every recipient as they are identified and as they are demonstrated to need liver transplantation. We're living in an age, however, when there's a critical organ shortage. We simply don't have enough organs for the amount of patients who need organs to survive. So there really had to be a system that was equitable and efficacious in terms of liver allocation. The ideal system certainly should be transparent. It should balance medical urgency as well as post-transplant benefit. The allocation system was derived based on this MELD allocation scoring system, which was developed to really answer a dictum by the government in the final rule, which said that we had to transplant the sickest first. So the modified and original MELD system accurately predict wait list mortality and has reduced the United States wait list mortality significantly using 4 common laboratory tests. So it's relatively easy to update and predict, but it's also incredibly objective and leaves, for example, our patients with cholangiocarcinoma at a significant MELD disadvantage, because these patients generally have healthy livers, so these numbers don't reflect how their need for transplantation, which is why it's really our need to consider other ways to find grafts. So there are exceptions built into the system because we understand that this needs to be done. Cholangiocarcinoma, hilar cholangiocarcinoma, is an accepted exception criteria, but intrahepatic cholangiocarcinoma is not. So what we did was we looked at this and recognized this as a problem or pitfall of the MELD allocation system, but instead of looking at it as a threat to our cholangiocarcinoma patients, we really use it as an opportunity to consider other, perhaps better ways to look for grafts. And this brings me to living donor liver transplant. So the consideration of a living donor to offer a piece of their liver as a graft to our patients with locally advanced intrahepatic cholangiocarcinoma, which does many things, most significantly offering an opportunity for transplantation, but also significantly, it offers us a very metered timing for transplant so that we can optimize the patient with adjuvant therapy prior to taking them to the OR, which allows us, I believe, to offer best outcomes after the transplant. So why can we do living donor liver transplant? Well, it really comes back to the Greek mythology, where we learned that the liver regenerates. The original Greek myth was that Prometheus was credited for the creation of man from clay, for the theft of fire from mankind, for mankind's use. He was sentenced by Zeus to eternal torment by being bound to a rock, where each day an eagle was sent to feed on his liver, only to have it grow back and be eaten again the next day. A very dramatic myth, but really one that's important and taught us that the liver, in fact, is a remarkable organ that can regenerate robustly. We've also developed a huge and very detailed understanding of the surgical anatomy of the liver. Dr. Fung really did some of the really important early work in his early experience with Dr. Starzl for us to understand how we could take apart the liver, not hurt the donor, and provide a graft which would be adequate for the recipients. So historically, living donor liver transplantation began as a means for parents of children with severe liver disease to donate a portion of their healthy liver to replace their child's entire damaged liver. We are very proud to say that the first report of a successful living donor liver transplantation in the United States was done by Dr. Christoph Brosch, who's shown here, at the University of Chicago in 1989. 2-year-old Alyssa Smith received a portion of her mother's liver. You can see her as a baby and now all grown up, married, and working. It's really a remarkable story. Unfortunately, though, the early experience with living donation was difficult. And it quickly became clear that we needed a lot of work to do to understand this process. The relative risk of graft failure in the early experience, this is back in 2001, just as this was being practiced for living donor recipients, certainly was significantly worse than that of a whole cadaveric organ. Furthermore, the relative mortality risk also was significantly higher with a living donor graft in these very early cases. There was only an N of 15 from 1998 to 2001. And then something terrible happened. A donor unfortunately passed away after they gave their brother a graft. And this was something which really halted the living donor community and made us really think hard about what we were doing. Importantly, all of the centers that really were committed to doing this and wanted to figure out how to do this well got together in this NIH consortium to form the A2All NIH consortium, which was the adult-to-adult living donor consortium, which was dedicated to really understanding the impact of living donation, both to the recipients and most importantly to the donors. I just wanted to very quickly give you some of the outcomes of A2All, which really changed the face of living donation. The first 7 years was the first iteration of the grant. It went from 2003 to 2009. There were certainly achievements, which were quite remarkable, but there are also failures to the grant. And therefore, there was a grant renewal for the next 5 years, which also importantly changed what we were doing with living donation. And I think has allowed us to consider this expanded criteria for liver transplantation with living donation in the cancer realm. So the A2All primary aims of the preliminary cohort study were to characterize the differences between living donation and deceased donation in terms of post-transplant outcomes, and to quantify the impact of choosing living donation on a candidate for transplantation. So really to look at those bad outcomes which were initially seen and understand how could we make them better. So when we looked at what we call the retro or bridge cohort, we saw something really interesting, which was that as centers gained experience doing living donation, and as surgeons, most importantly, gained experience, the outcomes suddenly got much better. This was an experiential problem. So as we learned to do living donors, as we learned who were the right donors and who were the right recipients, the outcomes were suddenly better than those that we saw with deceased donors, while those that were doing very few still had work to do to get to that level. Furthermore, the cumulative risk of death after a initial living donor liver transplant evaluation by a transplant group, interestingly, in those centers which had more experience, the risk of death on the wait list was down significantly, likely because we understood that we could offer people the grafts before they incurred the wait list mortality. We looked at post-transplant recipient complications and found that, again, experience matters. In centers that had more experience, although there were complications, they decreased significantly. And these could be seen most significantly in the biliary complications, where biliary leaks and biliary strictures were significantly less as centers became more experienced. So post-transplant survival after a living donor liver transplant and deceased donor liver transplant in experienced centers was equivalent, which was an exciting finding by A2All. The adult living donor community is associated with lower candidate mortality compared with waiting for a deceased donor liver transplant. And I think this is probably most significant for our liver transplant oncology patients. And the effect is certainly magnified in experienced centers. There's a lower mortality in living donor liver transplant recipients, which is associated with reduced exposure to waitlist mortality, and importantly, in careful planning to get to the operating room. And recipient complications also certainly decrease with experience. The next aim, which was important, was to assess living donor outcomes. So how did the donors do? What were their complication rates? This paper was probably one of the most important papers which came out of A2All, complications after living donor liver, after living liver donation, a prospective multi-center report. What it showed was there were complications. This operation is not complication-free. And I think as living donors come forward, you have to understand that although we as surgeons, our commitment is to make this as safe an operation as we can, we know that there are complications associated with any operation that we do, and our responsibility is to create the safest environment in which we can do this. And at University of Chicago, we really take this to heart, and every donor who comes forward is treated in such a way to make sure that their outcomes can be as good as they possibly can. One of the things that A2L did was they took a very common surgical grading system. It's called the Clavion Severity Grading System. It's used for across the board in surgical procedures. And we applied it to living donation because we realized this was an important way that we could kind of universally understand what the complications are after living donor hepatectomy. Grade 1, going grade 1 to grade 4 of course being the worst, that lead to liver failure requiring transplantation itself or death in a donor, or grade 1, which is simply any complication. I always tell my patients, if you're in the hospital after a donor and you stub your toe, that's a complication because you wouldn't have been in the hospital had you not given your liver. So these are all complications which are minor, but they happen and we have to acknowledge them. So when you look at the graded complications, again, experience matters, but when you look overall, it's important to see that although there are a lot of complications in living donation, the majority of them are grade 1 and grade 2, meaning that they happen, but they go away very quickly and they don't have long-term impact on the donor. The incidence of grade 4 complications, fortunately, is very low, and every day we are seeking for that to be 0. I understand that we will never get there, but that is always our goal and always will remain our goal. So in summary, in A2L, we looked at 231 living donors with prospectively collected data using a standardized classification. There was a 3% incidence of aborted donations, so people who went to the operating room and somehow in the middle of their case, we recognized that we could not move forward. So people who went to the operating room, went to sleep and had an incision. 29% of the patients undergoing living donor hepatectomy had at least one complication. The majority of those were grade 1 complications. The vast majority of biliary and infectious complications, which were the most common, occurred within the first 30 days. And a subsequent paper showed that by 6 months, 98% of those had resolved completely and never impacted the patient again. There were 4 grade 3 and 0 grade 4 complications in the prospective cohort. So importantly, no deaths and no retransplantations. So we believe these prospective data demonstrate that complications after living donor liver donation remain common and confirms our previous retrospective observations, but also confirm our need to constantly be better and constantly be finding ways to do this better. Surgical complications in this prospective cohort also occurred significantly less frequently than in the retrospective cohort, again, emphasizing that experience matters. The other things that A2L aimed to do was to determine short and long-term impact on quality of life after donation compared to control populations. And I personally think this was really one of the very important things that it did, because what we found was that people who donated really got a sense of achievement after donation, which is really remarkable. And we also understood that we had to standardize and assess the role of informed consent, because this was very different than any other surgical intervention that we were doing. And we've actually come to believe that in transplant oncology, especially for these diseases where we're really pushing the boundaries of indications, a new recognition of what informed consent has to be reconsidered as we bring living donors for intrapatic cholangiocarcinoma forward, to understand that we've really changed our outlook. We're no longer really looking necessarily for absolute cure, but rather long-term survival and quality of life as our measures of success. So A2L met all its primary and secondary objectives. The remaining questions were mostly in very specific scientific realms. We did get a renewal, which mainly focused on long-term donor health outcomes, because we felt that these were really important. We needed to understand what happened to donors long-term. So we looked at quality of life, safety, health informatics, communications and ethics, including informed consent, and really tried to make it equitable and diverse. We changed everything into language and education specific so that informed consent could really be as informed as it possibly could be. We looked at risks, we looked at econometrics, and we really found that adult to adult living donation is safe for both the donor and the recipient. The outcomes improve with experience. Donor complications persist, and it is our mission to continue to find ways to decrease them. Health status, safety, and other healthcare outcomes need further assessment. There was also a lot of questions about how far can we push our limits in terms of the size of the grafts that we were using, the types of grafts that we were using, certainly transferring the risk from our donors who are so generous and kind to come forward, perhaps to the recipient by changing the size variables. And certainly we are committed to more minimally invasive approaches, which were found to be safe and effective. So ultimately, why should we be doing living donors? Certainly because of organ shortages, because not everybody can get an organ on the wait list and the deceased donor wait list. Certainly to decrease wait times and wait list dropouts. But I would argue that in this realm of liver transplant oncology, there's a most important imperative to consider living donation, both because the wait list dropout will be significant and will impact mortality. But I'd argue also more importantly, because it allows us to plan and prepare for the operation to have the best outcome it possibly could, using multidisciplinary approaches, including chemotherapy and liver therapy, which allows us to plan for the surgery and optimize it at the time of the transplant. Why should we be cautious in doing living donation? I think we always have to remember this, because there are ethical concerns. We have to be careful about how we are informing donors. We know that there are donor complications, so we have to be very careful how we select patients. I know patients get very upset when they call and we say that we don't think you'd be an ideal donor, and it's not in any way personal. It's just that we know that we have to be the guardians of what we can offer, and we have to do it in a way that's as safe as possible. I also think we all have to acknowledge that unlike living kidney donation, where there is clearly superior outcomes with a living donor graft, the outcome benefit of living donation in liver is really the availability of the graft and the ability to plan and time the transplant. So what does it take to be a living donor? It's pretty simple in liver. You have to be blood type compatible. You have to be at our center between the ages of 18 and 55. 18 because we believe that you can't give a proper informed consent before that time. And 55 because although we're all aging better these days, every one of us, the liver senesces in a very real way. And the liver's ability to regenerate decreases at about 55 years old. The patient has to be healthy without any comorbid conditions, which may cause more complications. They have to be able to understand informed consent, and they have to be motivated by altruistic reasons. What they don't have to be is a family member. And I think it's really important to remember that you don't have to have someone directly tied to your social circle immediately as your only donors. You can really look out to a wide scope. So how do we improve the living donor process, and why aren't we doing more living donors specifically in this population of liver transplant oncology patients? I think there are multiple perceptions, which I hope I've addressed some of today. I think there are barriers in programs in terms of program experience and also program commitment to offering this type of approach. Certainly there's surgical approaches which vary across the nations. And importantly, we have to remember this idea of expanding our umbrella where we're looking for living donors. So anonymous, non-directed, and directed donors have become more important in the last several years, using social media as a way to really reach out and gather a community who are willing to come forward. Once you ask, it's remarkable how many people want to come forward. And certainly, I think that every recipient has to engage a donor champion, someone who is going to make it their mission to help that recipient find a donor, because the ask is absolutely the most difficult part. So I want to thank you for your attention. I would be happy to answer any questions. I know Dr. Fung would be as well. And again, I just want to thank the Cholangiocarcinoma Foundation for really supporting our efforts at University of Chicago, because it's really been a privilege to be part of the story for every patient who's come to us and has made it through our program.
Thank you so much. That was a wonderful presentation. I'm just going to let the audience know to please type in any questions in the chat and we can get to those. And anyone on Facebook Live, please feel free to throw some questions in the comments there as well. Lisa, I know you had a few questions. Do you want to start us off?
Hold on, I just lost.
I know what I was going to ask, because I'm sure some people weren't sure, and I wasn't sure if you actually said what it was, but when you were talking about de novo, what does that mean?
De novo means
Yes.
that it arises spontaneously or arises new. It's the Greek is actually from new. So de novo is like de novo malignancies means a new cancer, or so that's what the context is.
Okay, just wanted to make sure I wrote that down.
I wanted to ask, if a lot of patients that we talk to, they want to know, is transplant the last option for a cholangiocarcinoma patient, or at what part in the journey should it be considered? And would the timing of it potentially make it more successful for the patient?
So, that's a very good question. And I'll let Dr. Baker also chime in on this. I think, what Dr. Baker was showing was that the approach to doing even surgery and or transplant is to prepare the patient in an optimal way to make the operation, be it resection or transplant, more successful. So and we know from our experience with hepatocellular carcinoma, which is the most common types of liver cancer, that there are size issues, but also this sort of biological behavior, meaning that the longer the tumor stays, in a stable pattern, the better. And even if that stable pattern requires chemotherapy or radiation or whatever, the longer that you're able to show that the biologic behavior of the cholangiocarcinoma is more benign than aggressive, then the better chances that you're going to have after resection or transplant. So really the issue of timing for both is that we really try to see, is the multidisciplinary approach with chemo or targeted therapy or local regional therapy, as she was showing, able to consolidate the behavior of the tumor by slowing its growth down or making it regress or whatever, and then optimally deciding individually which is when you would go with a transplant. So for us, transplant would require what we call 6 months of stability. And that means also that you don't, and not having extrahepatic disease. It means tumor outside of the liver. Now, if the first regional lymph node, so you look at the way the drainage of the liver goes through the lymph nodes, it's possible that you could have a single lymph node that would come out with the resection specimen being involved as still being allowable. But we know that biologically, tumors that metastasize to the lymph nodes just biologically are worse off. But if you have a tumor in your lung, you have a tumor in your lymph nodes in the chest or whatever, or somewhere else, or a bone metastasis, then that usually declares that the tumor is not a biologically friendly tumor, and unless it regresses with immunotherapy or some targeted therapy, it's probably going to be recurrent fairly quickly after transplant. So we started to look at ways to minimize the recurrence and minimize the growth of the recurrences after transplant using more novel immunosuppressive agents. But it's just in the big picture, the biology of the tumor really dictates the outcome. So I think If it's a slow-growing tumor that is only confined to the liver, the PET scan shows that there's no involvement elsewhere, that's responded to chemotherapy. Those are the patients I think that do the best. And we'll consider every patient for whatever options, be it medically, radiologically, interventional radiology, or resection or transplant. But it is the least likely option that we can provide, simply because most of the knowing the cholangiocarcinomas, we know that most of these are outside of the liver confines by the time they're detected.
Thank you.
The only thing that I would add to that, thank you, Dr. Fung. I mean, I think that the most important thing as patients come to us with cholangiocarcinoma is everybody wants an immediate cure, right? So everybody wants surgery. And as a surgeon, of course, I think I can speak for Dr. Fung as well. Our instinct is we want to go to the OR. We would love to be able to offer a surgical option. I think we have learned that, as Dr. Fung said, the biology is really king, right? So we have to understand the biology. And we have to also understand that although something may be considered quote unquote operable immediately when we see a patient, that's not always the best option for that patient. We have to define what's going on. So the 6 months of stability with treatment, et cetera. I think it's really important that we're able to establish a treatment protocol which will allow us to demonstrate stability of disease or regression of disease prior to offering a surgical option. And Melinda, I think to your question, is everybody a transplant candidate? I think it's important to remember that part of this diligent patient process is knowing that we don't always know what the surgical option is going to be at the end game. Sometimes it's very obvious, sometimes it's less obvious, but it's our responsibility to really engage during that downstaging time to understand what the best ultimate surgical option is. And often that includes transplantation.
So something that goes along with that a lot of patients ask is, are there any treatments, because people are always planning plan A, plan B, plan C, plan D. Are there any treatments that a patient would have or procedures that would preclude them from eventually being a transplant candidate?
So I think that's a great question. And yes. So our experience with Hyaluronio has made us understand that if the tumor is biopsied in a way where the peritoneum or the inside of the abdominal cavity is violated, that can make someone not a transplant candidate because the potential for tumor cells that are spreading is there. And we worry about that very significantly when we have to give the drugs that allow a transplant to take, immunosuppressive drugs. So we know that that is a contraindication. So it is important on diagnosis to have a multidisciplinary team really consider what your imaging looks like, what your physiology looks like, what your laboratory values look like prior to kind of jumping into diagnostic and treatment plans.
Thank you.
We've got quite a few questions in the chat. Some of them I think you've already kind of addressed. So from a clinician perspective, is there advocacy to get the MELD exception points for CC patients like we have for HCC?
Well, that's a great question. Just from from a historical standpoint, you need to know that when liver transplantation started, most of the patients that were referred for transplant were large hepatocellular carcinomas, HCCs. The results weren't very good, and therefore the CMS, the Center for Medicaid and Medicare Services, actually made liver transplantation for HCC a contraindication. In other words, non-approved indication for transplant from 1983, when the consensus conference started, all the way through 1995. So the consequence of that was that until we could actually demonstrate that liver transplantation was a reasonable expectation for HCC for expectation of liver transplantation with reasonable outcomes, it just wasn't approved. Now, we've gotten a little smarter. I can tell you when we did our first series of cholangiocarcinomas, intrapatic cholangiocarcinomas back in the early 1990s in Pittsburgh, we're only able to demonstrate about a 23% 5-year survival rate. Because again, we didn't know biology, we didn't know much about, and we basically were transplanting, all comers. The results now were much better. We're using, some of the criteria that we just discussed, and some of the experiences that have come from, this consortium of cholangiocarcinoma programs around the country, including MD Anderson and the Memorial Group and the Methodist Group in Houston, and then some of the other programs that are beginning to explore. We have to be very careful at what we do, because if we take all comers and we can't demonstrate a good utility, it'll never get covered. Fortunately, I think some insurance companies have been liberal and given us some latitude, because we are, involved in a protocol, and we're trying to do things the right way. But we will be held accountable for our outcomes. If they're dismal, we're just shooting ourselves in the foot. And so that's been the challenge: is where do we balance that? The most important criteria that UNOS uses is a 1-year patient and graft survival. So, we will understand that some of the patients that we're taking are a little higher risk, and as long as we think we can get them past the 1-year mark, we'll be willing to be a little bit more flexible. But I can tell you, when you get a recurrence, we with the medical therapies that we have and the treatments that we have can often extend that survival for years. But if you get a recurrence, unless you can resect it, it's going to potentially lead to contribute to the long-term or short and long-term survival. But those are, until we have better targeted therapies that we can use post-transplant also. I mean, these are things that we're all incorporating as time goes on. And I think the promise is that, the developments that the cholangiocarcinoma community is seeing develop right in front of their faces can be adapted to post-transplant recurrences also. That's what we're hoping.
Thank you.
Good. Okay, so a question along the lines after treatment for post-transplants from Facebook. Thank you ever so much for this very informational webinar. At last year's conference, I asked about immunotherapy used for recurrence in transplant patients and was told there had been limited success with immunotherapy with transplanted patients. Is there any updated research or data on immunotherapy with transplanted patients now?
So I'm going to take immunotherapy comes in different forms. We traditionally think of immunotherapy as checkpoint inhibitors. These are molecules that block the negative interaction between the tumor and the T cells that kill the tumor. Those checkpoint inhibitors do have risk. They haven't really been used very much in cholangiocarcinoma. They have been used in hepatocellular carcinomas to a very small extent. The risk is that interaction, which suppresses tumor growth, is the same interaction that prevents rejection. And so when you're using checkpoint inhibitors in the post-transplant setting, you do increase the risk of rejection. You can actually induce lethal transplant rejection. So there are other checkpoint inhibitors that or immunotherapies that are also being developed, and I think some of these include tumor infiltrating lymphocyte or active lymphokine activated killer cells, that are more targeted to the tumor itself rather than directed to sort of this non-specific immune upregulation that we see with checkpoint inhibitors. And there again, some of the developments that are going on that we hear about at some of the scientific symposia that you hold some promise in that area, but we don't have a gun yet that will allow us to differentiate between tumor and transplanted organ.
Okay, so What is the best way to find out if someone is eligible for a liver transplant?
Talia, I'm going to let you take that.
I think the best way is to be seen by a center who is committed to this approach. It's important that all of the records get reviewed, all of the historical interventions get reviewed, the laboratory studies, and importantly that we see the patients. I would advocate that anybody who comes to a program for liver transplantation should also immediately, if you think that you're going to be a liver transplant candidate, you should also start considering whether living donation is something that is right for you. And I would argue that anybody who's a liver transplant candidate, especially if you are male disadvantaged, should consider the option of living donation.
Okay, great. Would tumor size and location affect the outcome of a living donor transplant?
So,
go ahead.
It's a good question. So again, every patient has to be considered individually, and not only the tumor size or location, but more importantly, the activity of the tumor. So how the tumor has responded to whatever treatment algorithm has been defined up front, and then to see that 6-month stability is more important than the actual physical absolute size or absolute number of tumors. The Methodist group actually defined that really nicely in their paper, that the size and number was less important than the biologic activity over the stability period.
Okay, great, thank you. Could you discuss further the local lymph node status and treatment in Hyaluronio?
So the Mayo protocol actually involves a look-see at the time that the chemotherapy is completed and before transplant. And again, like Dr. Baker's saying, a lot of the Hyaluronio experiences have inordinately depended on living donors because of the timing requirements from the chemo radiation therapy to the time of transplant. But they do a intervention at that point, either visually with a open procedure or laparoscopic look-in, or endoscopically through the intestine to see if they can find a lymph node. And if the lymph nodes look suspicious and they biopsy and it confirms that, then you are not a candidate to proceed to transplant. Now, as I said, our cases that we've done so far, we've really not had patients with positive lymph nodes, but biologically, as I said, there is a lymph node that sits right up in the crotch of the liver that, if it was positive, we probably wouldn't pick it up, or we're certainly not going to go after that. But if it's in the chain of lymph nodes further down around the head of the pancreas or down into the blood supply around the aorta or elsewhere, we would probably recommend not to do it unless there was a dramatic response to immunotherapy, as I said, or to chemotherapy. I think in that situation, we would likely not recommend transplant. But again, as Dr. Baker said, it really depends on the response. It depends on how your tumor responds to treatment.
Okay, another question. If one hospital has already denied you a transplant, is it worthwhile to try others, or will they say the same thing?
Talia?
I always think it's worth looking. I mean, every program has, because this is not a defined field yet, and it's an evolving field, and it's really every day we're learning new things about how we approach this disease. Every program has a different level of comfort. As Dr. Fung described, we're all measured on 1-year patient and graft survival. So every center has to have its own programmatic commitment to how they feel about taking on these risks. So absolutely, I think if you're denied at one center, it's worth looking at another. It's also looking at the reasons that you were denied. If there's something, if you have obvious extrahepatic disease, if you have disease progression, et cetera, those are different turn down reasons than a center who simply doesn't endorse this approach, which is perfectly reasonable at any given center.
Okay, thank you. And now if you're deemed not eligible for a resection, does that mean you're always not eligible for transplant?
No, actually, I think if you're not deemed suitable for resection, there are many reasons that you could not be. I mean, position of the tumor, the quality of the liver in general, if you have ongoing intrinsic liver disease, And treatment to local regional therapy can often lead to liver damage that makes it unsafe to resect. But as long as the tumor is confined to the liver, I think it's a reasonable option to consider transplant. There are other factors in transplant that you don't worry about in resection, your lungs, your heart function, your kidney function, all that other stuff. But if the locality and the response to treatment, location in the liver, and the absence of tumor outside the liver is probably the most important indication in stability, as I was mentioned.
Okay.
Thank you.
I'd like to hear some discussion of adjuvant therapy following liver transplant.
Dr. Baker actually was just reviewing this.
Okay. So we believe that adjuvant therapy should absolutely be a piece of the post-transplant care of a patient who has a transplant for these expanded indications. So we are very aggressive about first modulating immunosuppression. So immunosuppression are the drugs which allow us to not let our bodies reject the grafts. And traditionally, immunosuppression is given with calcineurin inhibitors as well as steroids. We actually very quickly changed from traditional immunosuppressive strategies to something called an mTOR inhibitor, which also has been shown not only to have immunosuppressive benefits, but also anti-tumor benefits in some liquid tumors. So we use something called everolimus or rapamycin very early post-transplant as our primary immunosuppressive strategy. We also, for cholangiocarcinomas, follow the BILCAP trials, just like those patients who are resected, and we start adjuvant capecitabine at about 3 months for 6 months post in everybody. We also are very committed in every explant, every liver that we take out that has tumor in it as we put in the new liver, we send that liver for genetic sequencing with the platforms that allow us to understand what other options for either, as Dr. Fung said, some of these really novel immunobiogenics or other opportunities for adjuvant therapy post. Everybody gets started generally on CAPE for the BILCAP trial, but then there are other options down the road as well based on what their explant genetic sequencing has shown.
Awesome, thank you. Would a metal stent preclude you from a transplant?
Sorry, what was the question again, Melinda?
Does a metal stent preclude transplant? I'm thinking it means exclude. Would that exclude you from being a transplant candidate is what I'm thinking.
I assume that they're talking about a metal stent in the bile duct system?
Yes, that's what I'm assuming.
No, I mean, we can put not often, but there are patients with benign liver disease where the stents are placed into the bile duct and we operate them, take them out. Yeah. The bile duct stents in general do pose an increased risk of infection post-transplant because they become colonized, and because many of those patients require multiple antibiotic courses leading into transplant, they often harbor resistant bacteria, and that can pose a problem. But as long as we know about it ahead of time, most of the time we're able to mitigate that risk by giving them very strong antibiotics. But no, that alone is not a reason not to pursue transplant.
Yeah. And also from just a physical standpoint, the stent generally comes out with the liver. So the bile duct comes out with the liver, so we take out the stent. And one of the things that I learned from Dr. Fung is these stents are usually colonized. So we actually culture them at the time of the transplant as we're taking them out and sending them off to the laboratories. And we really base a lot of our postoperative antibiotic management on those cultures.
That makes sense. Okay, I think last question, and I think you touched a little bit on this in the presentation. What are the current statistics of cholangiocarcinoma recurrences in patients after transplant?
Talia, you want to answer
I
I'll
would
give
say
you all the
we
hard
don't really
questions.
know. Yeah, we don't really know how to answer that because this is a relatively new and novel approach. There are many centers doing very many different things for cholangiocarcinoma. I think the most important thing that has happened over the last very few years is that we've developed these kind of multi-center collaborative consortia, really looking at this in a more established way so that we can start to give you those numbers. This is all very early data. All of us have a handful of cases which we could give you kind of experiential data on, but we really don't have enough data yet, enough patients yet to say what the long-term outcomes are. We believe they will be significantly better than what has been offered before. But I think it's with this optimism that we all go forward. It's how liver transplant itself was kind of started. It's how liver transplant for hepatocellular cancer certainly evolved. And now we're at a point when we're very fortunate to be in a position where we can expand these indications, although a lot of it is on faith and a lot of it is on a lot of dedication by all the key stakeholders who are taking a piece of this, including the patients who give us the privilege of being part of this and really give us the privilege of their patience in developing these protocols and understanding that we're learning as we go.
Thank you guys so much for the wonderful presentation and for answering all our questions. There may have been a handful of questions we didn't get to, but I will jot them down and send them your way, and maybe we can get back to the ones we didn't get answered. And this was recorded, so it will be on the website and shared on social media. If people want to go back to reference or share with other patients, that would be great. And again, we appreciate you guys so much and your time and the opportunity you gave us to explain everything for our patient community. And
Thank
Lisa,
you, Dr. Baker and Dr.
Right. Well, thank you for having us on, and like I said, we're always open to any questions or any advice that you might need. So good luck, everybody, and we'll see you in a few weeks at the Cholangiocarcinoma Annual Summit.
That's right. We'll be at the conference the end of March 31st, April 1st and 2nd. Don't forget to register.
All right.
Thank you.
Thank you.
Thank you.
Bye.
Bye-bye.